Dear colleagues, at first I would like to say it was my pleasure to participate of this beautiful meeting. I would like to show you a case from a young lady. She is 55 years old. I would say that she is a young lady for cardiologist. I think that our residents wouldn't understand what I'm talking about. But until now he was pretty well. She has hypertension and asthma, and she came to our emergency unit because she has chest pain in the last 3 days, especially in a small effort. When we see what she has for cardiovascular risk, then she is overweight, she's smoking, so bronchial asthma doesn't bother her too much. She is in perimenopause and she has high cholesterol, and from therapy she has only nebivolol for hypertension and her therapy for asthma. ECG was done, and we can see that she has ischemical changes in inferolateral leads, and that what we also see that she has elevation of ST in AVR lead. First, troponin in our emergency department was already elevated, and the lady was transferred to our coronary unit under the diagnosis no ST elevation, elevated infarction myocardial. When she got to the coronary unit, she was without chest pain. She was her ECG was much better than in coronary than in emergency unit, and she was rhythmological and hemodynamic stable. So under the early invasive strategy, next morning she was referred to our cath lab, and we perform coronarography. We use right radial access. Right coronary artery is working as video also. It's not bad. Then we tried. Then I try to see what is going on with the left coronary artery. But there was a little bit trouble with insert catheter into the left main. I thought that it was because she has angulation in arch, but when I made indirectly, it seems to be fine. But I decided to change catheter. But once again, I couldn't insert guiding into the ostium, and if we did indirect picture, we saw what's the problem. And we can say that usually don't see that lesion that comes. So in ostium of LAD, usually we see at the end of LAD with bifurcation with second LAD. But now we could think a little bit what is our strategy and what we can do with that lady. But that was not happening because patient complained of the chest pain right away. And she said, it's hurting bad, I'm not good. She was restless, she couldn't lay anymore on a table. For a few minutes she becomes dyspnoic, she gets acute heart failure, she has a severe drop of pressure, and she's developing cardiogenic shock. So, then we decided, to do intervention. We don't have to wait, we don't have time to wait. And we took EBO catheter, and the position was not very well, and it took us for a while to put another catheter into the ostium of left main because of this lesion. At the end, we get this position. We took a wire and we put wire in a first vessel that we can get. It was CIRC. Does it playing? No. And if you ask me if we see I was here or something, the answer is no. The lady was really in bad condition. And what we done? We dilated, put a stent and a very short pot in this position, and that was the final result that we get. Can we see the result? The final result seems to be fine. The left main was open, and we were very satisfied with that. Then we stopped, we didn't do anything else. The lady was transferred to the coronary unit. She needed non-invasive ventilation. She needed congestion therapy and inotropes. But after 1 hour, the lady was much better, relief from the chest pain. We get good pressure, and the maximal of troponin was not too high at all. Before discharge, her ejection fraction was very good, and only what we see, it's a little bit hypokinetic apex. What the guidance says, did we do it right in this patient? Yes, we can perform urgency PCI with a patient with non-ST elevated myocardial infarction, especially with cardiogenic shock. And I would like to say here that we have here one slight recommendation, and I think that experts that sit under those C, that they really think that when we consider short-term mechanical circulatory support in such patients, that they think about the lady like I show you here. So she has really good prospects of long-time survival and prediction of quality of life if we succeed this. I would like to emphasize that we are working in center without any possibility of mechanical circulatory support. And when you work like this, and when you have patient like this, and when you have so rapidly deterioration of the patient, and when you are aware that you don't have bailout strategy, it's really stressful to continue to work that. And I would like to say that that's situation in Croatia, and that we really need to work it out. And Susan pointed out today that we have to have those centers, but we have to think about volume. And if we didn't manage to put that stent here in this patient, I don't know what we're going to do with that. We didn't have any time and chance to transfer that lady from our cath lab to anyone else. What we decided with her, she was released to home, and we decided to see this angio once again after 1 month, and we will perform IVUS to see development of the stent and if we done everything fine. Only briefly, I would like to say a few words about a gentleman. He's still in our hospital. He's 73 years old, and we know already that he is very ill. He has permanent atrial fibrillation. We know that he has cardiomyopathy with mildly reduced ejection fraction. We know that he has moderate mitral regurgitation. He has his depression, and he has emphysema. He came into the emergency because deterioration of his condition. He has dyspnea, intolerance of exercising, peripheral edema. He came with atrial fibrillation with fast ventricular response. He has his therapy, and we understood that he has acutization of his chronic failure. The idea was that we need to do hospitalization, decongestion, rhythm control, optimize his heart failure therapy, and to see if there is some other reason why he get worse now. He has already known renal impairment, and his BNP was very high. When we look at the echo, can we see that, please? And we look at transthoracic echo. He has mild mitral regurgitation, but with very eccentric mass. But when we measure that, it's still moderate. And I was not satisfied with that echo, because I was thinking it was really eccentric jet. I can do lots of errors, and next time I decided to do transesophageal echo, and the morphology here was the same. That regurgitation jet that came here. But when I change the angle, we see here that morphology of anterior leaflet, it's not the same, and that here we have some changes. And when we put color Doppler here, then we see that we have a big jet that came from this portion, and that we here have perforation of A1, A2 scallops, and that he has not moderate but severe mitral regurgitation of that perforation. That jet was really big, and we decided to see if that is really perforation. We perform also 3D ultrasound, and you can see here this hole that we find on transthoracic ultrasound. He has additional problem with his right ventricle and with pulmonary hypertension, and his angiogram was without coronary disease. And we perform also catheterization of right heart. The pressure in a pulmonary artery was the same as we measure with ultrasound. He has really elevated pressure in right ventricle and right atrial diastolic especially, and what concerns us, that is really high pulmonary vascular resistance that we measured. We discussed about this guy on our team. The surgeon decided to do replacement of this valve. He said that he is not to be possible to repair, and during the operation he will decide if he is going to make tricuspidal valve repair also, or only annuloplastic with prosthetic rings. What concerns us, that every sign that is associated with worse outcome he already has. He is 73 years old, he has also renal failure, and he has emphysema. So we are really worried about his operation that is going to happen next week, and perhaps in another meeting we will tell you what we get. Thank you for much.